Hi, it's Dr. Centeno, and thanks so much for joining us here today at You've Got the Power. Now, I didn't know if I was going to be on today, but I decided to do the slipping rib syndrome topic that one of our viewers suggested a couple weeks ago. And I'd really love for you, if you're watching today, to suggest some topics that I haven't yet covered, because it's always good to have those kind of in my back pocket for days where there's not something specific coming up that really needs to be dealt with right then and there. So same format as previous. We're going to go through a short review of the topic. I'll show some slides. Today, the focus is slipping rib syndrome. Now, I know a lot of CCI patients watch this broadcast, both live and later on video. And in my experience, a lot of CCI patients have rib issues, and we end up treating those in those patients when they're there. Also, rib issues are surprisingly common, but often underdiagnosed. So we're going to go into that today. As usual, you can ask questions about that topic. You can ask questions about anything else. It doesn't really make a difference to me. So we'll get started. I'll go ahead and share my screen. Looks like that worked. And I will put up today's topic, and we'll get started on that. Again, today's topic is slipping rib syndrome. So slipping rib syndrome, this is kind of a weird name, to be honest with you, even though that's the name that you'll find on Google that really represents what we would call rib instability. So again, it's a not so elegant way to describe the concept of rib instability, meaning the rib or a rib or some ribs aren't stable. But if you look it up on Google, you'll see this slipping rib syndrome. So we'll use these two terms interchangeably today. And given that traditional medicine tries to see if you can find this on an X-ray, it's usually the lower free-floating ribs that are being referred to when you see this topic, slipping rib syndrome, because those can be malaligned much more commonly and seen on X-ray. And this whole thing is more common in HEDS patients with hypermobility. So hypermobile Ehlers-Danlos. So how common is this problem? Well, if you look on Google, apparently they claim it's super rare, but we see it all the time in patients with chronic thoracic pain, kind of in this area, obviously in the back as well. And about 1 in 4 of those patients have some chronic rib instability. Again, our term rib instability, the term that Google uses, is slipping rib syndrome. So it's much more common than it's diagnosed. And I think that's why you see so many people going on the internet trying to figure out what's going on. It feels to me like there's a rib that's the problem, but I went to my doctor and maybe he said I had costochondritis or something like that. He didn't really go here. So I think that's why we see so much searching around this topic, and probably why it was brought up by one of our viewers just a couple weeks ago. So the rib instability pain is interesting because it kind of wraps around. Now, it doesn't always have to wrap around. Sometimes it can be just a little spot back here, and then people generally notice a rib out there. Or sometimes it kind of starts here and very much goes and wraps around to the front. And patients usually understand or notice that it can be modified by taking a deep breath. They'll feel it when they take a deep breath in, when their ribs are moving. And you can have pain in this area. Sometimes the sensations are electric, numb, or burning. Now, when they're electric, numb, or burning, it may be slipping rib syndrome / rib instability, or it also could involve an irritated spinal nerve or even a intercostal nerve under the rib. And if it's due to the lower rib, it can refer to the stomach. So I think I've told this story a few times now. We had a patient with a rib issue and a disc bulge at like T11 or T12. It was wrapping into his stomach, and he got the $1 million GI workup when all he really had was a lower rib cage issue. So can you image this? And regrettably, x-rays and MRIs are usually not all that helpful. And the only caveat will be when there's also a thoracic disc bulge out there pressing on a nerve, and that sort of causes this pain that wraps around the rib. We'll obviously see the thoracic disc bulge, but there also can be rib instability. So in that case, you'll see a disc bulge, and you'll see some segmental muscle atrophy. Now, the segmental muscle atrophy won't be usually on the MRI report, but the thoracic disc bulge may be. But for the most part, this is a diagnosis based on clinical history and an advanced hands-on exam, palpating each rib and looking for abnormal rib motion. Now, this is not a common skill set. In fact, you're much more likely to find a physical therapist or chiropractor that can get to this diagnosis of an unstable rib than you are an MD or a DO. So regrettably, amongst MDs like myself or traditional physicians, this is usually not in their skill set, this physical exam part that we're talking about down here, and that's why it goes underdiagnosed. So rib anatomy, a couple things just to note. You've got the connections in the front here, and there are also some ligaments here in the front that will bond the rib to the sternum, which is up front here. And there's usually these pieces of cartilage here that attach the rib. And then we'll talk about in the next couple of slides all of these ligaments that live in the back here. But as you can see, you've got the rib cage, right? The rib cage attaches in the front and attaches in the back. Now, from a biomechanics standpoint, there's bucket handle motion. There's also something called pump handle motion. Bucket handle motion is probably the one to be most aware of, and that means that the rib acts a little bit like a bucket handle as you take a deep breath in. So as you take a deep breath in, the rib will go up and out. And then as you let that breath out, the ribs come down. So the ribs have normal motions that can be palpated. And if you do it a couple hundred times, you can get a sense of when they're not moving normally. And again, that's much more likely to be found by a manual trained physical therapist, which is the minority of them, or a chiropractor, i.e. folks that palpate rib movement all day. And obviously I can do it as a specially trained physician, but you're not going to see a lot of doctors that can do this. So, regrettably, your average family doctor, orthopedic surgeon, neurologist, this is going to go over their head. So what does instability mean? Because I've been talking about rib instability. It means too much motion, usually because the ligaments are damaged or stretched. So what keeps the ribs stable? We talked about there being some ligaments up front here where the ribs come into the sternum. And there's two other major components I'm going to really show you, and that are the ligaments attaching the ribs to the spine and sternum, and the fascia that surrounds the ribs. So the rib attachments to the spine from the posterior here are pretty intense. You've got a thoracic vertebra over here. You've got the rib here. And then there's lots of bits and pieces in here. You've got this lateral costotransverse ligament there, attaching the transverse process of the thoracic vertebra to the rib. You've got these attachments of the ribs to the spine called the superior costotransverse ligament, so the rib to the transverse process of the spine. And then you've got these intertransverse ligaments that aren't really attached to the ribs, but help with thoracic spinal motion side to side. So the two to really be focused on here are these lateral and superior costotransverse ligaments. Now, these are not easy to see. They're not easy to treat. And if you're treating rib instability through injection, which we'll talk about in a little bit, you have to know these are here. You have to know how to target them. And again, that is not a common skill out there, which is why this stuff rarely gets appropriately treated. And now this is from the front looking towards the back. So we still see that same superior costotransverse ligament, but from the other side. We still see the intertransverse ligaments, but from the other side. We see the rib here. And the reason for showing you this view is to show you that there are these radiate ligaments that are around the actual rib where it attaches to the spine. So those also need to be treated from the backside. Now, on the backside view, it was not easy to see that radiate ligament, which is why I'm showing you it from the front, looking towards the back. Also realize that if you've ever eaten any ribs, right, if you just go to a rib place, you'll notice that the ribs have this tough fascial covering on the outside. And that rib fascia is critical in controlling rib motion. And so inside here is the muscle, and the rib fascia is this blue line that you see going across, both on the outside of the rib cage and on the inside of the rib cage. So that also has to be targeted if you're going to treat this stuff. Now realize that you want that done by someone with a lot of experience because the lung is in here. So if the needle doesn't go to the right spot, it can go into the lung. Bad day for everyone. So these injections have to be done very, very carefully, usually these under ultrasound guidance, to be able to avoid doing that. And this just shows you how that rib fascia works. If you inhale, then that expands the rib cage and the fascia gets tight. When you exhale, the fascia gets loose and thicker. So thin and stretched, thicker and loose, depending on how you're breathing. Now, as you might imagine, if you damage this fascia, then the ribs aren't going to have even motion, because this is one of those things that is controlling that motion. So if you damage this fascia for some reason, let's say you get hit in the rib cage or you're hypermobile, then the individual rib's going to start moving to places it shouldn't move. So what are the treatments for slipping rib? Well, physical therapy with an emphasis on manipulation of the ribs, which is the vast minority of physical therapists that are trained that way, or chiropractic can usually help. Now, for the patients who fail those, precise orthobiologic injections that can use both X-ray and ultrasound into the involved ligaments and fascia works well. So things like platelet-rich plasma directed into those areas can get rid of this problem. Prolotherapy will oftentimes work as well. Surgery is rarely needed to treat this. And here, we see one surgical solution. I just found this online randomly, but again, not needed for 99% of the patients that suffer with this problem. So we don't need to drill holes and put in pieces of suture to try to keep the ribs together. And thankfully, I haven't actually seen a patient who's ever had this done. So I'm assuming this is fairly rare, because we see hundreds of rib instability patients a year. So I'm assuming this is not being done that often. So in conclusion, slipping rib syndrome is much more common than it is accurately diagnosed out there. So it's underdiagnosed, in my opinion. It's really just rib instability. And manipulation can often help, but when that doesn't work, we should be focused on precise injections of all those structures I talked about to provide rib instability. So let me stop that sharing, and then I will go here and see if we have any questions about this topic or any other topic out there. Looks like we have a couple. Stacy. Oh, thanks, Stacy. I think I actually picked this one out instead of my wife, so that's good. Fetchant, can someone have C0, C1 instability without C1, C2 instability? Yes, we certainly have seen that. Stacy, does this include the top rib that supports the neck? Meaning the first rib. So I think what you're talking about there is that in the first and second and sometimes third ribs, we have the scalene muscles that come from those ribs and go up. So yes, those can be unstable as well. Dr. Centeno, what are the best methods for diagnosing head pain and head pressure? Yeah, none of those are going to be accurate ways to diagnose head pressure. So MRA, CT venogram, cerebral angiogram are not going to be accurately able to even to put people in a this person's experiencing head pressure box and this person isn't. So those aren't real great ways to get there. And as far as measuring pressure in the head, the only way to do that is to float a catheter, usually from the lumbar spine, up in through the head. But I can count on one hand the number of patients who have had that test done that I've seen out there. So that's a good way to diagnose head pressure, but I can't say that opening pressure on a lumbar puncture, which is very, very commonly used as a substitute for that, is going to be all that accurate, right? You've got the pressure up here and then a long, long water column, and then you're measuring at the bottom of the water column. You don't really know what the pressure is up here. You're kind of guessing. So regrettably, those are not good ways to diagnose who has the symptom of head pressure. Fatchin, if the neck above C2 spinous process feels quite soft when pressed with a finger, like you can push inside. Yeah, Fatchin, that certainly could be one explanation for that, which would be muscle atrophy in that area, because you shouldn't be able, to push in there because the muscle should provide good resistance. So I'm assuming that that's what you're feeling. Now, obviously, I can feel your neck, take a look at your MRIs and try to say why that's happening. We can even look under ultrasound and see what's going on. It's been advanced by Stacy. My ribs have popped out on occasion. Could this be caused by AICCI, caused by a car collision and ensuing thoracic pain? Could the tight muscles, coat hanger, pain be pulling the ribs out, or are the muscles too weak? In my experience in patients involved in car crash type trauma, there's often direct injury to the rib cage fascia and ligaments. So that's usually what we see there, is the rib cage fascia and ligaments start to develop problems or were injured directly. Now, it's certainly possible that if you have chronic CCI, that could sort of pull things out up top here, because that's where those scalene muscles attach, and the scalene muscles may be overworking. But a lot of patients who have had a car crash also have direct trauma on the ribs. So for instance, a big one that we see is when the airbags deploy, it's kind of like an explosion. It's pretty violent. And it's pretty violent because it has to get out there in such a short period of time. So it has tremendous acceleration. So if you happen to be a smaller person and get exposed or hit by the airbag in the chest, that could be enough to tear enough of these ligaments to cause this kind of problem. Paulo, yeah, I'm pretty sure you were the guy that asked about it. So I wanted to make sure we did this. And again, if someone else has some really cool things for me to talk about, please put your topics into the comments, because it's great to hear what you guys want to hear. And then I can dive deep into that and try to do a presentation on it. Regenics, made advanced by JT. I was recently hospitalized for a pain in the area of my chest. and had a full cardiac and gastro workup, nothing. Yeah, so that is the problem. And I think I mentioned that in the short lecture I did, and that is that like CCI, these are patients who often don't get the proper diagnosis. They go through these $1 million workups. They are seen, just as is discussed here, they're seen by cardiology because they're having chest pain. Well, cardiology does its thing. The EKG is normal. There's no increased enzymes, so it's not the heart. Then they go to gastroenterology, and all sorts of scopes are done and different tests, and it's not that. Again, if you've got this rib pain that seems to radiate and that changes as you take a deep breath, especially when it's aggravated, this is something to consider. Now, it also could be a thoracic disc bulge, an irritated thoracic nerve, lots of other things, but regrettably, this thoracic spine problem doesn't really get worked up very often, because even if you see a musculoskeletal doctor, they're going to look at your neck and your low back, and for some reason in the thoracic spine, which is in the middle between those two things, they don't look. Or they put in WNL, which is our abbreviation for within normal limits. But the joke sometimes that we used to talk about as doctors means we never looked. So long story short is it's very hard to find the right doctor to do this. You're not going to find many out there. I would suspect that of all the different musculoskeletal doctors I know and respect, a small minority accurately diagnose this issue on a day-to-day basis and treat it. So even amongst really highly thought of musculoskeletal practitioners, this often goes unnoticed. Regenix, Harry Winston, I'm reasonably sure I have this. As alga cells treat this? I don't know the answer to that. I haven't asked them, but you may want to go and just obviously ask them if they treat rib issues. They certainly have the tools to do it, but I don't know if they treat this or not on a day-to-day basis. My PT does it. Yeah, so again, you're more, as I said in the presentation, you're more likely to find a manual trained physical therapist or chiropractor that can diagnose this than you are the average musculoskeletal specialist. So your orthopedic surgeon, it's going to go way over his or her head. Neurologist, way over his or her head. But if you go to a manually trained physical therapist who knows how to examine the rib cage, much more likely for them to be able to diagnose this. Sherry, I think this is what I had years ago. Every time I went to the store to get giant boxes of cat litter that were very heavy, I would have to lift them out of the shopping cart and into the car. It was incredibly painful. Lasted for several days. Haven't had a cat in 20 years. Never happened since. Well, it's a good way to maybe, reason not to keep a cat. But in the meantime, yes, heavy lifting can prompt this kind of thing. Angela, can rotator cuff cause issues to rib pain on the opposite side? Less so. If it feels like rib pain, it probably is coming from the thoracic spine and ribs. Now realize that, the rotator cuff and the shoulder, which I didn't really go into here, kind of float on the rib cage. And they're attached only through muscles and fascia. So it's not uncommon to see rib cage issues and rotator cuff issues at the same time, but usually they're on the same side. Carol, have a friend with a recent hip replacement. She's interested in platelet stem cells to help her bone health, to either help maybe osteoporosis is what you're talking about there. No, there really isn't a platelet-based or stem cell-based osteoporosis treatment at this point. Paulo, I have clicking in the back of the ribs and a very strong pain in the ribs in front, very sharp and strong in the back. Also for 9 years, I've done 7 procedures of prolotherapy, but I've only had 50% improvement. Pain is every day. How can I was treated without surgery? Yeah, Paulo. So most prolotherapy, as we talk about here, is done blind. Now, the good news is if you're relatively thin you can accurately treat along the rib. So I'm assuming you say you had prolotherapy, that they treated all the way along those ribs that hurt, from the back out through the side into the front, where it attaches here. Now, regrettably, all of those little ligaments I showed you really can't be accessed with blind prolotherapy. You would need some very highly trained physician who knows what to look for, and then do that under ultrasound guidance to treat all those little ligaments we talked about where the ribs attach to the thoracic spine vertebra. So my guess would be, to get the other half of this, you would probably need those ligaments treated. That's assuming they're treated all the way around. The other thing is that there's sometimes overlap here between, as I said in the presentation, a thoracic disc bulge, which has gone undiagnosed, irritating a thoracic nerve. That's part and parcel of this, in which case we would inject platelet lysate or platelet growth factors specifically around that disc and nerve under X-ray guidance with contrast. So it's a bit more, it's a couple levels above the kind of treatment that you had, but it can usually get patients the rest of the way. Stacy, how long would you wait after PRP injections for resuming natural anti-inflammatory supplements like fish oil? Yeah, I'd get out of that inflammatory phase. So that's really going to be 4 to 6 weeks in there. Now, listen, if you restarted it right away because it was really helpful for you, I doubt it would put a big dent in the outcome, just because we're suppressing the lipo-oxygenase pathway and not the cyclooxygenase pathway like NSAIDs do. ZA, when performing the PICL on someone with significant pannus, how do you ensure that the stem cells are injected in the alar and transverse ligaments, not into the pannus? Well, certainly not into the pannus, but realize that most of the time, what we see when a patient has significant pannus is there's a big bursa there, and that bursa is inflamed and fibrotic, meaning that it is scarred down. So our goal is to try to get patients before the pannus starts, but this is one of the downsides of having had upper cervical instability for many years, where a pannus forms. And what the pannus really is just the bursa, or the lubricating sac there, that has a very thickened wall. So we may well get inject into that bursa. What we do, though, meaning that's with contrast, we will then reposition into the alar and transverse ligaments and generally stay out of the bursa, because injecting into the bursa is probably not going to be all that helpful. And just realize that it's one of the downsides of having this issue for a long time, meaning that bursa gets scarred, and that is what we call a pannus. Can injecting the pannus make it bigger, compressing the brainstem further? Could that be why some people get worse? I looked at that issue and it didn't really pannus, but play on words there. But in looking at people who seem to have a pannus, it was totally random as to whether or not they were in that very small group of patients that had that long-term flare-up. So I doubt that that's the cause. We're not going to make it any bigger, but just realize that if you've had this long enough to have a pannus, you're kind of in a different category. You're in that this has been going on a long time category. So there's starting to be changes in the body that really aren't going to go away, meaning that while if you get stability, the bursa may calm down. The scarring of the bursa is not going to change. Stacy, if not having rib pain in your office and can't remember which ribs have gone out, can you determine what needs to be injected? Does rib need to be out when you treat? Not necessarily out when we treat, no. So that shouldn't be a big deal. Sherry, I have a dropped right shoulder, a tilted upright scapular off the rib cage, and pain in the back of my rib cage. Yeah, so all of that could be associated with what we're talking about, or other things in the shoulder girdle, as the shoulder girdle sits on top of the ribs. Could the temporary inflammation post-styloidectomy with improved CCI symptoms to the point of function like normal suggest posterior PRP could be very beneficial? So it sounds, let me just try to deconstruct that. So it sounds like post-styloidectomy, there was temporary inflammation, which seemed to improve the CCI symptoms. So on the one hand, that's good, right? Meaning that we always talk about that honeymoon period. And the honeymoon period is just that period of time when things are swollen, the ligaments are artificially tight, and the patient feels much better because of that artificial stability. Having said that, styloidectomy destabilizes the anterior cervical spine. So we're always going to put styloidectomy patients into the harder to treat category because you can't cut ligaments for free, right? All those ligaments are there for a specific reason. So if you start cutting them like the stylohyoid ligament, we're going to destabilize that anterior cervical spine. So on the one hand, yes, that's a good sign. On the other hand, having had the styloid cut is not a good sign for what it is we do. Regenics, mid-advance by Kelly McCauley. I slip a rib in my upper left chest all the time. It's scary, feels like a heart attack because the nerves will pinch, hurt all the way into my back, can't even breathe. No telling how many times I was in the ER, I think you had an embolism or a heart issue till it was caught. My doctor felt it and taught me stretches to move it back. Yeah, so that's, so listen, if you can do it with conservative care and some specific stretches that will get rid of the problem very promptly and easily, that's a good thing to do. If you can't do that, or if this becomes a disabling issue, then injection-based care can usually get it more stable. Stacy, I have a fusion for scoliosis, T4 to L4. When I used to see Dr. Reeves in KC, he would inject along the sides of the spine. My doctor in Denver is only injecting the neck, shoulders, and lower back. Sacrum, am I missing out on not having a problem in the middle of my back? Well, so if you're fused from T4 to L4 and you're having rib-based issues, the fusion didn't do much for the ribs. So the fusion stabilized the spine. So it wouldn't make much sense to inject the actual spine itself because the spine isn't moving. And prolotherapy would be specifically to tighten ligaments in the spine. Having said that, if you have instability in the rib cage, then the fusion isn't really doing anything for the rib cage at all. So then you would want to go ahead and get those ribs treated there. So yeah, that's definitely something to consider, is getting the rib cage itself treated, just as we talked about here. Now, I don't know if that's indicated or not, but that would make sense to me given what you're describing. How much time do you recommend between posterior PRP treatments? Usually 4 to 6 weeks, in that range. A lesser amount of time for that than we would PICL. So in the spinal ligaments, no, there's probably not much reason for doing that. But if it's in the rib cage, then yes, that would make more sense. Do you treat the anterior longitudinal ligament during posterior PRP treatment? No, there's no way to get to the anterior longitudinal ligament during posterior PRP treatment. Can't be done. Let's see. So other questions. I knew we were going to probably have fewer people today just because today is the MLK holiday. But if there are other questions I can answer, just let me know and I'll be happy to answer them. Era. Can AI, when C2 is bent backwards and the skull tilted backwards, it'll be true with PRP or PICL reliably, and your skull is lowered? They can't rotate properly left or right or move head down properly. So in AI, when C2 is bent backwards and the skull is tilted backwards, so I probably need to know a little bit more, but it sounds like what you're talking about are the anterior ligaments that live between the skull, the atlas, and C2. that go by lots of different names, everything from AAOM to SAAOL. And those can be treated during a PICL procedure from the front. So I think that's what you're discussing. As far as the position of the head relative to the dens, not important to us because we're looking for instability. So if there's instability causing that, the focus is reduce the instability. As far as trying to fuse for that, not a big fan, but obviously there's some patients that might need that type of fusion. Paula, what if the rib is hypermobile or is injured? Or what if cartilage is broken in the front? We often don't see the cartilage broken in the front. That is something that could be looked at on an MRI if there's a question about that, because that would show up. Usually what we're talking about is the rib is hypermobile. So all of those ligaments and the fascia that we talked about got injured somehow, someplace, and eventually that became symptomatic. Can't you roll someone over after posterior C-spine PRP to inject the ALL? Not really. It can be certainly done that way, but just realize that that's a higher risk procedure. So can't be reached from the back, but if we wanted to do a separate procedure to treat the ALL, that's possible to do. Just realize that's a much higher risk procedure than just treating the ligaments in the back. So probably about 10x the risk. Now, good news is treating the ligaments in the back is super low risk. So 10x that isn't huge, but realize that there's a lot to miss up front here. So we have to miss the external carotid artery, the internal carotid artery, the phrenic nerve, which controls your breathing, the cervical sympathetic chain, the vertebral artery in front of the spine, just to name a few. So none of that is an issue when we're injecting back here, other than when we're injecting high up in this area where we have the vertebral artery. So just realize that it's a much higher risk procedure to treat that. So we always look at risk benefit. Does it make sense for that person? John, is nuchal ligament ever injected? All the time. Is nuchal ligament key in stabilization for CCI? I mean, it's certainly a player. It's just not a major player. It's a minor player. So if your instability is in flexion, then the nuchal ligament will come into play and it should be treated. But for instance, you can also have laxity in the transverse ligament, and tightening the nuchal ligament isn't going to do much because the transverse ligament is internal. And so while it might help reduce a little bit of C1, C2 motion, it's not going to change a lot if there's a transverse ligament injury in there. So it's one of the players. It just got an accessory part rather than the main stabilization part like the internal ligaments do, alar accessory transverse. Angela, when I breathe, it's sore, but it also can sometimes cause itching along the spine. I don't know much about the itching along the spine part, but if it's sore to breathe, many times that can be a rib issue. It's been advanced by Bob Black. Is there any way to prevent a rib that consistently pops out of place? My doctor suggested a fusion of the related spinal disc. So a fusion in the thoracic spine is a high-risk procedure because we have to deflate the lungs in order to do that, and that buys you an automatic ICU admission after a thoracic surgery. So a fusion also wouldn't make much sense because that's not going to change anything about that rib. So yeah, this is what this conversation is about. There are injection-based treatments that can help what you're describing. And those injection-based treatments are very specific to the fascia and the ligaments that hold the rib in place. As far as doing a spinal fusion in the thoracic spine to treat that, no, that wouldn't make much sense. And obviously it's a high risk thing to do. Sorry, just clarify. So you mentioned the best way to diagnose head plane pressure other than a lumbar puncture. So the ones you mentioned aren't good options. What is the best method in your opinion? Beth, I think that we've discussed this before, but what we're talking about here and the concern is that there's no way to tie increased pressure in your symptoms. So let me give an example. So let's say in the interventional spine world, a block is very common. So what's a block? Let's say your 0-1 facet joint was actually causing this pressure. And someone could inject your 0-1 facet joint. They could numb it out. And within 5 minutes, since the pain generator is numbed, the symptoms would go away. And we would say, yes, it's the right 0-1 facet joint. Now, we may or may not see anything on an MRI with regard to that facet joint, but let's say we saw a little swelling on the MRI there. And on exam, we could press on that joint, and it was tender, and it generally seemed to cause your symptoms, or it seemed to be in the same area as your symptoms. So now we've got a pretty good story that 0-1 facet joint is causing your pain. Those kind of stories don't exist with this whole intracranial hypertension concept, right? Because there is no block I can give you that would take away the head pressure. And even if we know there's increased pressure up here, I have no way to determine with any accuracy that increased pressure is causing the head pain. So it's one of these academic issues. I mean, you may have increased intracranial pressure, but so might 10 people walking down the street right now out of the 100 that are walking past a certain point in a city who don't have any increased head pressure or symptoms. So tying that to symptoms is always going to be next to impossible. So it's kind of an academic issue that doesn't really get us any place because it's not tied to any kind of treatment. Now, one area where it could be tied to treatment would be seeing someone like Scott Rosa. And Scott can do some very sophisticated cerebrospinal fluid flow studies. And then he can do those before and after chiropractic, very specific vector upper cervical adjustment. We can actually document, yes, the person's headache went away, and yes, the fluid flow out of the skull got much, much better. So now we've got a story that makes sense, right? We've got a patient with pressure headaches on the one hand, right? One. And then two would be there was a backup or some sort of obstruction of cerebrospinal fluid out of the cranium into the spine. And you could see that on a CSF flow MRI. And then three, Scott was able to reposition things. And then not only did the headache go away, but the fluid flow got better. So now we have got a great story. Yes, that's what was causing your headache. But outside of the way Scott does it, we're not going to be able to link anything to a treatment. ZA, does posterior PRP usually do the job in regards to also having laxity in the ALL? Is the ALL not a major player in regards to instability symptoms? I mean, it could be. I would need to take a look at your images to see if it, so if it looks like there's a retrolisthesis of a specific segment, and that segment looks like it's causing your symptoms, then that would be a rationale to treat the ALL directly. But posterior PRP won't change much about the ALL. Giovanni, if you're a very functional CCI patient but still suffer from chronic dizziness, like myself, where the risk of PICL may not be worth it, but the symptoms are still persistent, what would you recommend when you're on this fine line between severe and not? Yeah, it's usually just treatment of the upper cervical spine. So posterior PRP into the ligaments and usually high upper cervical facet joints is what would be recommended, short of PICL. So that will usually help in that case if there isn't severe instability. Now, if there's severe instability, then it may not help at all. But that would be a good half step to try, especially if the chronic dizziness is disabling, right? If it's just very mild chronic dizziness, you can drive and do everything else you need to, then maybe not even worth doing that. But if it's chronic dizziness that prevents you from doing X, Y, and Z, and you need to do X, Y, and Z, then that would be a reason to consider getting it treated. Stacy, it is only a short 3-day honeymoon period after PRP, indicative of anything. Certainly could mean rapid turnaround of inflammation, which is good because, again, the honeymoon period would be when the ligaments are swollen and tighter, things feel better. Now, for some of our patients, that can last 2 weeks, but that's not necessarily a good thing because 2 weeks of inflammation after an injection like that, of acute inflammation causing the ligament to be tighter, means that that person has a very aggressive inflammatory response that doesn't resolve quickly. So if you look at young people, right? Young people who don't have all the metabolic disease and all the other stuff we tend to get as we get older, they can turn around inflammation incredibly fast, usually in 1 to 2 days. So if they go out and play basketball and the ankle swells, by the next morning the swelling's gone, or maybe the day after that the swelling's gone. A 50-year-old does that, and the swelling might last 7 to 10 days. So what you could be describing is just a rapid turnaround of inflammation, which is a good thing, not a bad thing. Unit. So I have a constant pain in my left upper back ribs and around the left scapula, but from time to time, when I lift my arm over my head, it feels like something's going out of place in the upper back, left ribs region, but no chest pain or any specific pain associated with particular sensation of something going out of place. Could this be slip rib syndrome? It certainly could be. It also could be related to the scapulothoracic bursa or the bursa between the scapula and the rib cage. It also could be related to a lower cervical facet joint issue. Lots of different things can cause pain in that specific area. Okay, guys, I am out of questions. Any other questions that anyone has about anything going on here that we've been talking about or anything else? Happy to answer those. So today, just to start wrapping this up, we've been talking about this concept of slipping rib syndrome or rib instability. It's much more commonly out there than it is diagnosed. So it's, in my opinion, underdiagnosed, but relatively easy to treat if you know what to treat. And that's often the problem, is these poor patients, like many of the CCI patients, sort of are like a pinball in a pinball machine going from specialist to specialist to specialist. Some of them will eventually get the diagnosis of chondrochondritis, meaning kind of just a painful rib or an inflamed rib. But treatment for this is available and not hard to do if you can specifically guide those injections into the rib fascia and specific ligaments. Stacy, how do you know when it's time to stop PRP and do another PICL? Really, for any treatment like that, if you're continuing to get improvements in your pain, then I would keep moving forward. So if pain, symptoms, function, we're all going the right direction, and that's changing 15% or more per treatment, then I think you can certainly continue whichever track you're on, whether that be PRP or PICL. However, if it goes below that and you're trying to convince yourself of 5%, then it's time to stop the track you're on. So that's generally how we look at that. Now, obviously, if there are things we're following, like C1, C2, we'll certainly look at that as well, independent of symptoms, meaning if someone's showing good improvements in their overhang and they may not have changed symptoms yet, we could continue. Now, why do we use 15%? Because in the studies, 15% is the smallest amount that a patient was able to bin. What I mean by bin is if they had 5% change, that seemed to be statistical bounce. It wasn't real. It needed to be about 15% or more for it to be an actual clinically meaningful change to the person. John, how often does your clinic do PICL? Almost every clinic day. I do my PICLs on Tuesdays and Wednesdays. Dr. Schultz generally does his on Thursdays. So pretty much all the time. unless obviously someone's out, etc. Okay, guys, I am going to start closing this up. So we were talking about slipping rib syndrome and rib instability in general. Again, a very, very underdiagnosed thing, but it can be treated if it's diagnosed. So thanks so much for watching today. And happy to answer any questions I didn't get to next time. So save those for this coming Friday, where we will do this again. Also, if you have any kind of suggestions for various topics, then feel free to leave those here, and we'll try to go ahead and get to those at a later date. So thanks so much for watching. You all have a wonderful holiday weekend, and I will see you this coming Friday. Thank you.